Hi, my name is Joni Rabiner, and I am Pediatric Emergency Ultrasound faculty at the Morgan Stanley Children's Hospital at Columbia University Medical Center in New York. I am very excited to be here today to talk to you about pediatric point-of-care elbow ultrasound. For our goals and objectives today, we will go through the indications for point-of-care elbow ultrasound, probe selection, image acquisition, normal anatomy and pathology, some pearls and pitfalls, and we'll end with a case. The indications for elbow ultrasonography include elbow trauma, which is very common in children, and up to 15% of fractures in children will involve the elbow. We can also perform elbow ultrasound for elbow swelling of any etiology or suspected annular ligament displacement, more commonly known as nursemaid's elbow. We will use a linear transducer for this application as we are evaluating superficial structures, and this will give us the highest resolution images. The setting should be set as musculoskeletal, soft tissue, or small parts, depending on your ultrasound machine. The depth should be adjusted so that the full bony cortex of the olecranon fossa in the posterior elbow is visualized. When I started performing musculoskeletal ultrasounds, I was hesitant to scan children in an area of injury. However, I quickly learned that kids actually tolerate musculoskeletal ultrasound really well, and the key is to use a lot of gel. If you use a lot of gel, you can minimize the amount of pressure needed to obtain images in an area of pain. So step 1 for image acquisition is to use a large amount of gel on the probe. Step 2 is to place the probe on the posterior elbow with the patient's elbows flexed to 90 degrees. As with any ultrasound application, we want to scan in perpendicular planes. In step 3, we will start in the longitudinal or long axis, with the probe parallel to the distal humerus and the marker towards the patient's head. In step 4, we will scan in transverse or short axis, with the marker towards the patient's right side. You can fan through the posterior elbow to fully visualize the structures in both of these planes. I highly recommend scanning the contralateral normal elbow first for 2 reasons. First, you get a sense of the patient's normal anatomy, and you have a comparison if there are any questions about what you are seeing on the affected side. Second, it shows the child what you will be doing so that they are prepared when you need to image the affected side. Lastly, be sure to use all techniques available to you to help get your images in as child-friendly manner as possible. You can scan the child in their position of comfort or on their parent's lap, use warm gel, have child life there and/or distraction techniques while scanning, etc. The curved ends of bones at joints can be difficult to evaluate directly for fracture with ultrasound. For elbow ultrasound, we will be evaluating the elbow posterior fat pad as a marker for fracture at the elbow. Here we can see that the elbow posterior fat pad is intracapsular, or inside the joint capsule, but extrasynovial, or outside the synovium of the joint. Therefore, when you have an elbow effusion, we can see how the elbow posterior fat pad is pushed and will appear elevated compared to the normal elbow. Ultrasound can detect this elevated posterior fat pad, which indicates intracapsular elbow fracture. Of note, ultrasound is more sensitive than X-rays for posterior fat pad elevation, with 5 to 10 milliliters of fluid necessary for a positive posterior fat pad sign on X-ray, but only 1 to 3 milliliters of fluid necessary for identification of an elevated posterior fat pad on ultrasound. Therefore, ultrasound will detect smaller effusions or injuries than X-ray. This is what we see on ultrasound when evaluating the elbow and long axis. Here on the left is a long axis view of the distal humerus at the olecranon fossa with a normal posterior fat pad. This is the cortex of the distal humerus and olecranon fossa. So your distal humerus and your olecranon fossa. Here are your triceps muscles. And this is your posterior fat pad sitting nicely in this olecranon fossa below this continuation of the distal humeral line. So this is a normal posterior fat pad. Here on the right is a long axis view of an elevated posterior fat pad. Here's the cortex of the distal humerus and your olecranon fossa. There's the triceps muscle, and this is your posterior fat pad that's elevated above this continuation of the distal humeral line. Here are video clips of a normal elbow in the long axis on the left with the posterior fat pad sitting nicely in that olecranon fossa, and on the right is an elevated posterior fat pad with the fat pad rising well above the distal humeral line. Here on the left is a short axis or transverse view of the distal humerus at the olecranon fossa with a normal posterior fat pad. Here's the cortex of the olecranon fossa. These are the triceps muscles, and this is your posterior fat pad that sits nicely in the olecranon fossa below this line connecting both sides of the olecranon fossa. Here on the right is a transverse view of an elevated posterior fat pad. Here's the cortex of your olecranon fossa, and this is your posterior fat pad that rises above that imaginary line connecting both sides of the olecranon fossa. Here are video clips of a normal elbow in the short axis on the left with the posterior fat pad again sitting nicely in that olecranon fossa. On the right is an elevated posterior fat pad with the fat pad rising well above the line connecting both sides of the olecranon fossa. Lipohemarthrosis, which in the setting of trauma represents blood and lipid material in the fat pad, appears as hypoechoic areas within the posterior fat pad. Here we have longitudinal and transverse views of an elevated posterior fat pad with lipohemarthrosis, which is the hypoechoic or dark areas of the fat pad seen here. We performed the largest study of point-of-care elbow ultrasound to date, which was published in Annals of Emergency Medicine in 2013, to examine the test performance characteristics for point-of-care ultrasound performed by pediatric emergency medicine physicians compared with radiographic diagnosis of elbow fractures. This was a prospective study of children up to 21 years of age, presenting to the emergency department with an elbow injury requiring an X-ray. A positive elbow ultrasound was defined as elevation of the posterior fat pad and/or the presence of lipohemarthrosis. 130 patients were enrolled with a mean age of 7.5 years. 43 patients, or 33%, had an X-ray that was positive for fracture. Point-of-care elbow ultrasound had a sensitivity of 98% and a specificity of 70% for diagnosis of elbow fracture. This is different from most other ultrasound applications that have higher specificities and sensitivities, and it means that a patient with an elbow ultrasound that is negative for posterior fat pad elevation and lipohemarthrosis is very unlikely to have an elbow fracture. Therefore, we concluded that POCUS of the elbow is highly sensitive for elbow fractures, and a negative point-of-care elbow ultrasound may reduce the need for elbow X-rays in children with elbow injuries. Once we learned that elbow ultrasound is highly sensitive for elbow fracture, our next question was, how can we apply this in our emergency department? We went on to do another study looking at elbow point-of-care ultrasound in the pediatric emergency department and its potential effect on outcomes. We enrolled 100 children with elbow injuries in the pediatric emergency department requiring elbow X-rays with a mean age of 7.9 years. Elbow ultrasound was performed by pediatric emergency medicine physicians who then determined whether they thought radiography was still required. All patients had X-rays and clinical follow-up, and 42 patients had fractures. The median time for ultrasound was 3 minutes versus 60 minutes for X-ray. X-ray was no longer desired by the physician in 23% of cases. Elbow ultrasound had a sensitivity of 88%, but in all false negative ultrasound scans, the physician still desired an X-ray. Therefore, elbow ultrasound combined with clinical suspicion for fracture had a sensitivity of 100%. We concluded that elbow ultrasound has a high sensitivity to rule out fracture and is best used in patients with a low clinical suspicion of fracture. The use of X-rays, and therefore costs and emergency department length of stay, may be reduced in patients with a low clinical concern for fracture and a normal elbow ultrasound. This meta-analysis of ultrasound for pediatric elbow fractures was published in Annals of Emergency Medicine in 2019. They analyzed a total of 10 studies, including 519 patients, and found that elbow ultrasound overall has a sensitivity of 96%, specificity of 89%, and area under the receiver-operator curve of 0.97 for diagnosis of elbow fracture. They determined that the overall false negative rate for elbow ultrasound was 3.7%. This data further supports that elbow ultrasound is highly sensitive and may be better as a rule-out test. These authors concluded that elbow ultrasound showed high performance in the diagnosis of pediatric elbow fractures. Most importantly, they went on to state that ultrasound may be performed by trained physicians as a first-line diagnostic tool to diagnose pediatric elbow fractures. Elbow ultrasound may help you evaluate your patients with suspected annular ligament displacement, or nursemaid elbow, as well. Nursemaid elbow occurs when the annular ligament slips over the radial head and becomes entrapped in the radial humeral joint. It is a clinical diagnosis, but it may have overlapping signs and symptoms with elbow fracture, which may occasionally confuse the diagnosis. In this prospective study of children with nursemaid elbow, diagnosed clinically and successfully reduced in the emergency department, 83% of children had normal posterior fat pads on elbow ultrasound, with 14% having elevated posterior fat pads and 5% having lipohemarthrosis. However, on review, those called positive had minimal findings, unlike those with true fractures. Therefore, in a child with a questionable diagnosis of nursemaid elbow, a negative elbow ultrasound may reassure you to attempt the nursemaid reduction without obtaining an X-ray first. These days, ultra-portable handheld ultrasound machines are available and being used more frequently. Are handheld ultrasound machines just as good as our standard cart-based ultrasound machines for musculoskeletal applications? This was a study of 100 patients imaged with portable handheld and conventional cart-based ultrasound for musculoskeletal applications performed by radiologists in an outpatient radiology clinic. They found that musculoskeletal diagnosis with handheld ultrasound was concordant or discordant without clinical relevance in 96% of their patients. This is an area ripe for research in pediatric point-of-care ultrasound, but this is reassuring that handheld ultrasound machines are likely non-inferior to our standard ultrasound machines for musculoskeletal applications. Now we'll review some pearls and pitfalls with elbow ultrasound. First, some pearls. Scan the contralateral normal side first, as it may be helpful to know what the patient's normal anatomy appears like, and it will help put your patient at ease when scanning in an area of injury. Use a lot of gel to minimize the pressure in an area of injury. And as with any ultrasound application, scan in perpendicular planes. And some pitfalls. Radial neck and medial epicondyle fractures may occur without an associated elbow effusion, as they are located outside of the elbow joint capsule. Therefore, if you have tenderness over the radial neck or at the medial epicondyle, even with a negative elbow ultrasound, you should still evaluate for fracture with an X-ray. Of note, in a series of children with elbow fractures, 14% were radial neck fractures and 8% were medial epicondyle fractures, so elbow ultrasound will detect the vast majority of elbow fractures. And remember that the specificity is lower than the sensitivity, so some patients with a positive elbow ultrasound may not have an associated elbow fracture. And now for a case. We have a 6-year-old female who presents after a fall from the monkey bars at school today, now reporting right elbow pain. She has no past medical history and no other complaints today. On physical examination, her vital signs were stable. Her extremity exam was significant for tenderness to palpation at the elbow joint with decreased range of motion at the elbow. Her pulses are intact. There is no tenderness to palpation or decreased range of motion at the shoulder or wrist. Our differential diagnosis for this child with elbow pain after a fall includes a supracondylar fracture, other elbow fractures, an occult elbow fracture, or a soft tissue injury. POCUS is performed. First, we look at her normal elbow to see her anatomy and to get her familiar and comfortable with elbow ultrasound before performing it on her injured arm. Here we see a normal posterior fat pad in longitudinal and transverse views. Now we scan her affected elbow, and we see a significantly elevated posterior fat pad in longitudinal and transverse views. The patient's ultrasound results of an elevated posterior fat pad concerning for elbow fracture was shared with the family. Her pain was reassessed and treated as needed. She was made NPO in case a procedure was needed, and orthopedics was consulted. She had an x-ray that showed a supracondylar fracture with a moderate elbow joint effusion. The patient was casted by orthopedics and discharged home. In summary, elbow ultrasound has good test characteristics for evaluation of elbow fracture in children, with higher sensitivity than specificity. A recent meta-analysis showed an overall sensitivity of 96% and specificity of 89%. Elbow ultrasound may help reduce x-rays, cost, and emergency department length of stay in patients at low risk for fracture with a negative elbow ultrasound. Elbow ultrasound may help expedite care for those with positive findings on ultrasound. And elbow ultrasound may be especially useful in low-resource settings without easy access to other radiologic imaging. Thank you so much for joining me today. Please feel free to reach out via email with any questions or comments, and have a great rest of your day.